and what we can use in this indication and what in this indication. Selection of the proper and most appropriate instrument is one of the keystones for performance and of successful hysteroscopic surgery, taking into consideration the wide variety of available instruments. Firstly, the expected advancement in any field of endoscopy is the form of energy used, whether laparoscopy or hysteroscopy. Here we have 4 forms of energy: is the mechanical one, the monopolar electrosurgery, the bipolar electrosurgery, the classic one, and the VersaPoint, and lastly is the laser surgery. The mechanical instruments, including all the instruments all of us know: scissors, biopsy forceps, myoma screw, and second one is the morcellator. Monopolar surgery and bipolar surgery, whether the standard one or the VersaPoint, and the laser surgery, the laser energy. Each type of this energy obligates utilization of a distinct distension medium, meaning for the mechanical energy, bipolar electrosurgery and laser, you can whatever media you want, whether electrolytes, ionic media, or non-ionic media. And the main problem here with this is the volume overload in lengthy operations. With the monopolar electrosurgery, you have the problem of utilizing electrolyte-free distending media, and you have here 2 problems: either the fluid overload or the electrolyte disturbance, mainly hyponatremia, its effect on the brain. So we wanted to escape of the problem of these lengthy operations and these problems of distending media, making the operation shorter in duration and safer as regards the media we utilize it for uterine distension. In the hysteroscopic morcellator, it is a fast, that's the first point, single-step tissue excision and removal. While you are excising the tissue, you are not excising the tissue only, but removing it at the same time. The handle, it has a resecting blade, and at the same time there is a suction to remove the tissue at the same time. So you will achieve excision, removal, fast in one step. In the use of the morcellators, there is no electricity, no electric current passed in the body of the patient. And this is actually an important step, especially if you are using in comparison with use of monopolar, and the injury with a monopolar is actually dangerous in comparison with the mechanical energy. A fast excision and removal in a single step, limitation of operation time, decreased fluid absorption, no volume overload. The mechanical mechanism of action keeps the specimen integrity for histopathologic examination. كلنا عارفين القصة بتاع المورسيليتور، الابدومينال مورسيليتور وامريكا، وان المورسيليتور تقريبا وقفوه علشان no histopathology examination and so on. Here in the hysteroscopy, you are keeping the integrity of the tissue and you are preserving it for histopathology examination. We have to concentrate here that are 2 types of morcellator, not only one type, according to the direction of movement. One is oscillatory movement. Oscillatory movement. The other one is rotatory plus go forward and backward. And this is very important. This forward and backward movement together with the oscillatory movement will enable you to perform the different pathologies: adhesions, septum, myoma, visual DNC, and so on. The oscillatory movement will enable you to perform only the myomectomy and the polypectomy. The morcellator with oscillatory movement is suitable for myomectomy or polypectomy. The morcellator with simultaneous rotatory and reciprocal movements can be used in the different pathologies: myomectomy, polypectomy, septum excision, intrauterine adhesiolysis, and diagnostic visual DNC. You are performing visual DNC diagnostic. There are important technical steps we have to note during utilization of the morcellator. Keep the resection removal window. There is a window which is cut in firm contact with the tissue you want to resect. and you are keeping this firm contact by application of the suction before application of the excision maneuver. So you are activating the suction at first, then activating the rotatory movement. Adjust the suction power. You have to adjust suction power little bit below the distending volume to keep the uterus properly distended. Keep the bipolar electrode at hand for the possibility of the bleeding. Use prostaglandin the day before the operation to avoid the necessary unnecessary mechanical cervical dilatation. This actually, the resectoscope, the morcellator with only rotatory oscillatory movement. This one, as you see here, that's the resecting blades. These blades only oscillatory movement. And this is a bipolar electrode used with it at need. This is a machine for the source of motor, the motor driver, and the other one for suction. This is the other type which is used using two directions of movements, the rotatory movement together with the forward and backward movement. This is the distension bump with it. This is the windows here. This is the inner blade is moving forward and backward and rotates at the same time. And through these two directions of movement, you can perform different pathologies in contrary to the previous type. This is different handle sizes to adapt for the size of the myoma or the tissue you want to resect. This is the way how the morcellator is working. Don't know how we can activate this video now.
في حد في
Can we go out, finish هطلع بره خالص فين الماوس؟ الماوس بس مش That's the way how it works. Actually, it is very rapid. Within few minutes, completely removed. You know, there is no flakes of tissue or the tissue remaining in the uterine cavity because at the same time it rotates, it absorbs the tissue outside. That's a large myoma. Here is a different technique that is utilized in this one. They divided the myoma into two halves to facilitate its removal. Then the tubal ostium, localization of the tubal ostium before then. That is a rotatory movement. Actually, if the myoma have an intramural extension, it may be a little bit difficult to go inside the myometrium and remove it. We are still utilizing this morcellator. Recently, we will try to use it for these intramural myomas, but I think it will be difficult. We have utilized it for removal of intrauterine adhesions and utilize for septum resection. It is marvelous in the intrauterine adhesions actually, but this not this one from Storz, this is the other one from Hologic or from Smith and Nephew. As you see, you can utilize it in very short duration of time. You are just utilizing saline. There's no lengthy operation. It is a short time. Actually, a big myoma, it takes about 20 minutes. No volume overload or no hyponatremia, and no use of electricity. You actually, you are not in need for utilizing this bipolar electrode so much. Rarely you can use. You can resort to it, but I don't know whether you have a large intramural myoma, you may need it actually. But it is marvelous in especially in the adhesion also, because we cannot imagine. We performed one case of tuberculous intrauterine adhesions. The cavity was completely destructed, but we can restore the form of the cavity, and still we are waiting whether this function or not, the endometrium, but it is safe. It is markedly safe when you compare it with utilizing electrosurgery and such dense adhesion or something like that. Thank you.
Thank you, Professor Hisham, for this nice presentation. Our next talk would be about hysteroscopy and ART by Professor Ahmed Abdallah from Kenya University.
Bismillahir Rahmanir Rahim. I would like to express many thanks to Professor Ahmed Abu Nasr and Professor Ahmed Zakaria and the organized committee who invite me to participate in the conference. My topic today about the role of hysteroscopy in assisted reproduction. Despite the great advances in the field of IVF and ICSI treatment, however, the implantation rate per embryo transfer is only around 30%. As we know, implantation failure represents a major clinical challenge and is a cause of considerable stress either to clinician and or patient in ART, in addition to high cost of the fertility treatment. Many investigators put possible causes for implantation failure in the form of embryo quality, uterine receptivity, or combination of both, but remains unfortunately unexplained in many cases. In many publications, the prevalence of unsuspected uterine pathology in asymptomatic women with implantation failure has been reported to be as high as around 50%. Bacchus et al. 2013 and other investigators reported that the sensitivity of diagnostic hysteroscopy is significantly higher than transvaginal sonography and hysterosonography in the diagnosis of intrauterine lesion. Therefore, one of the common investigations proposed for women with undergoing IVF and ICSI treatment is to evaluate the uterine cavity through hysteroscopy. As we know, hysteroscopy is the gold standard test for assessing the uterine cavity. In addition, it not only provides accurate visual assessment of the uterine cavity, but also provides the chance to treat any pathology in the same setting. After the great advances in development of hysteroscopic tests and instrument, we have office hysteroscopy, which is visible as a routine examination even without anesthesia. Currently, there is considerable evidence that hysteroscopy before starting IVF and ICSI treatment could increase the chance of pregnancy outcome in women who had previous failed IVF and ICSI cycle or cycles. However, many recommendations regarding the efficacy of a routine use of hysteroscopy prior to starting the first IVF treatment cycle, however, are still lacking. Bundir et al. In 2013 addressed the impact of routine hysteroscopy prior to the start of the first IVF cycle on treatment outcome, and their conclusion, the results were mainly improved when hysteroscopy performed just before commencing the IVF cycle. In addition, the benefit of hysteroscopy could extend beyond the correction of the uterine pathology in the field of ART in the form of either embryo transfer, more accurate embryo placement, enhanced endometrial receptivity second to endometrial stimulation or injury. All these factors are explanation for improved IVF and ICSI outcome even after normal hysteroscopy. The impact of hysteroscopic myomectomy on pregnancy outcome show in many investigations, as addressed today also, clinical pregnancy rate ranging from 30 to 70 post-hysteroscopic myomectomy. Ilmazni 2011 also reports that a small endometrial polyp less than 2 centimeters don't decrease the pregnancy rate after IVF, but increase the pregnancy loss. The impact of hysteroscopic metroplasty on pregnancy outcome also addressed by many investigators, and there is a marked improvement after surgery and increasing the pregnancy rate and decreasing the miscarriage rate. Currently, hysteroscopic hydrosalpingic occlusion by insertion of Essure intra-tubal blocking device prior to IVF and ICSI is a reasonable option in cases where laparoscopic salpingectomy is contraindicated. The European Society of Human Reproduction and Embryology ESHRE guidelines indicate hysteroscopy is not recommended as a routine investigation in the fertility workup because of a lack of strong evidence, and only for the confirmation and the treatment of the doubtful intrauterine pathology. Again, the Royal College of Obstetricians and Gynecologists reported that hysteroscopy is a grade B recommendation in fertility assessment and treatment, and is not included in the initial infertility workup unless indicated. Currently, there is a large INSIGHT study protocol titled Cost and Effect of a Routine Hysteroscopy Prior to the First IVF Treatment Cycle, will be studied in 26 IVF and ICSI European centers and I think will solve the problems. The result of this randomized study, which are expected in 2015, will help to clarify the significance of hysteroscopy prior to a first IVF and XC treatment cycle, because this study is a randomized study. Mr. Chairman, my colleagues, lastly, in conclusion, there are currently 3 policies regarding the role of hysteroscopy before assisted reproduction. The first one, hysteroscopy is recommended when there is a suspicion of intrauterine pathology at histosonography, transvaginal sonography, or sonohysterography. The second recommendation, in failed IVF X treatment cycle or cycles, despite normal histosonography, transvaginal sonography, or sonohysterography. Lastly, and necessary, hysteroscopy is still a matter of debate as a routine employment for all patients before assisted reproduction. Thank you very much.
Thank you, Professor. Our last topic for this session would be pain at office hysteroscopy, and this will be presented by Dr. Khalid Abdelaziz, lecturer of obstetrics and gynecology, Cairo University.
Thank you, my dear Professor Dr. Muhammad, for introducing me. Thank you, Mr. Co-Chairman, and I would like to thank the organizing committee for giving me this chance to be with you today. I'm presenting on behalf of my esteemed professor and colleagues our work. We first announced that we have no conflict of interest, and we would like to say that our work has been recently published in Middle East Fertility Society Journal. Dr. Muhammad Sharif Zayed, my dear Professor Dr. Muhammad Zayed, and my also dear colleague Dr. Osama Fouda. Office hysteroscopy is considered a valuable addition to the outpatient diagnostic modalities in gynecology clinic. But in order to gain the title office, this must be an easy way of doing this hysteroscopy without complication and with less pain. So several studies have shown that office hysteroscopy by the vaginoscopic approach is a well-accepted, tolerable procedure without the need of analgesia or pain medication, with a limited failure rate of less than 4%. However, in other studies by Dr. Zayed et al., there was a need for pre-medication or spontaneous use of local anesthesia. A larger study by Cesanelli et al. In 2004, including 8,000 patients, the pain ranged from mild in 10% of cases up to 0.5 in severe pain. Similarly, some other studies were studying about the failure rate and pain, how much they are reduced, and they said that if the scope is less than 4 millimeter, that will be less pain. So if we have a way to know which patient will need this pain preparation or even preparation of the cervix before working, that would lead to higher rate of success in doing the hysteroscopy and also decrease the pain during this hysteroscopy. In that search and literature for the causes that might cause pain during hysteroscopy, parity has been suggested, the mode of delivery, whether cesarean section or by vaginal delivery, the menopausal status, the presence of cesarean scar section, the effect of surgeon's experience also, and the diameter of the scope has been studied. The aim of our study that we studied 6 factors, which is the parity, the menopausal status, the menstrual cycle phase, whether doing the hysteroscopy in the proliferative or the secretory phase, and the cervical pathology, the presence of cervical pathology or uterine pathology, and at last the duration of the procedure that we take. To do this, we conducted a prospective study over a year, including 254 patients, all had informed consent, and these were the different diagnoses that we met during the clinic. Some patients came with infertility, some cases with abnormal uterine bleeding, also some cases referred for abnormal findings on the ultrasound and abnormal histology, and some cases with missed intrauterine device. Contraindications were taken into consideration, and office hysteroscopy were in all cases was done using the vaginoscopic Betocchi and Selvaggi approach that was described in 1997. We used an outer-to-outer diameter system of 4.3 millimeters with a scope of 2.9 millimeters. Saline was used as a standing medium, and the pressure used was set between 80 and 100 millimeters. There were no pre-medication given to the patient during their waiting time, and at last, cervical preparation was also not done. Throughout the procedure, a visual contact was maintained with the patient to observe the patient response to pain, and also the tolerability while interacting with the patient, explaining findings of the procedure. At the end of the procedure, the total duration was done, and she was given a visual analog score to score pain, either having no pain, giving a score of 0, or mild pain up to 3, moderate pain up to 7, or severe pain up to 9, and intolerable pain giving the score of 10. This is an example of a universal pain assessment tool. Of course, the faces here are used for children or people with decreased mentalities, but we use something like this line in telling the patient to assess their pain. We had a group, a little number of patients, which we failed to do the hysteroscopy, failed to introduce the hysteroscopy, while the successful group was divided into group A and group B. Taking into consideration that our aim from the study is that to know that if we can possibly do this hysteroscopy without pain or accepted pain, or there will be much pain which will interfere with doing this hysteroscopy. So we divided score up to 7, which includes no pain, mild pain, or moderate pain, which is accepted or tolerable to the patient, and the group B with severe or intolerable pain from 8 to 10. We used the statistical methods, a student t-test or Yates correction equation. If the numbers were less than 5, we considered p-value less than 5% to be significant, and we used multivariate analysis to ask to take away the bias. So as if for example, non-leprous patients had pain, but all of them were menopausal, which factor is consistent more with pain? This video nearly summarizes our results. It shows also the technique that we went by, the Betocchi approach. This is now we are in the cervix, doing cervicoscopy and talking with the patient about the findings. Here we can find some hyperemia in the cervix. We are trying to find our way to the internal os, which will be spotted now. Now I wish you would have a look at the eyes of the patient, the face of the patient, while we were doing this. This is the most crucial step during office hysteroscopy, entering the uterine cavity. As you see here, on the first attempt, things were a little bit difficult, so we took our time, inflated more water, and then, without touching the uterine wall, we succeeded to go inside the uterine cavity to watch a beautiful cavity inside. These were our results. The green area you can see here are consisting 34% of patients in our study that experienced no or mild pain. The blue area, 47% of patients showing moderate pain. This mounted up to 81% of patients that had mild or